Welcome to Envision New Mexico, AHI New Mexico this morning. And we did want to cover just a few items that you may have heard before, but in case you haven't, here we go. The session is being recorded, so please don't include any confidential patient health information during the session. You are on video by default, and if you do want to be off of video, then you can use the button on the left-hand bottom of your screen to mute that, as well as your microphone. We'd like to hear from you, but if you need to mute, then that's how you do that. If you wish to receive CMEs or CEU certificates, please announce your name here in just a minute when we have roll call. You can always use the chat box if you prefer, or if you don't have access to audio. And here's another screen on video and audio. Again, that's in the bottom left of your Zoom screen. If you do need to join by phone, there's an option there for that as well. Our disclosure and accreditation statements are on screen now. And we do want to mention case consultations, a big part of AHI New Mexico this year. Next week and the following week, we have case consultations. Forums, that's going to be exclusively for the case consultations. And so we're not going to have a didactic. We're going to have our panel of experts here and discuss the cases. The point of all this as well, or the second point of this, is Molina Healthcare, Blue Cross Blue Shield New Mexico can reimburse you if your patient is with one of those entities. So it's up to $150 from Molina and about $75 from Blue Cross. So it is definitely worth billing. And there's no limit at this point as far as how many of those you can do. So please take advantage of that. If you have any questions, contact myself or Michelle Whitener. And we also have an asynchronous version of our AHI New Mexico sessions on Moodle, and those are just about caught up as of yesterday. And so you do need to register for Moodle and the course, and then take the course. Best thing to do is to get in touch again with either me or Michelle Wagner for more information on that. And I see several people are chiming in on chat. And but if you can, go ahead and unmute bottom left of your screen and tell us who you are and where you're from.
John Taranjo from Mora, New Mexico, school-based health center.
Hi, John.
Hi, good morning.
Morning.
Good morning. This is Valerie Romero-Leggett from the Youth Services Center and University of New Mexico Health Sciences Center.
Well, good morning, Valerie.
Morning.
As Kevin mentioned, I can see many of you guys are typing as well. And can I just say, Kathleen and John, thank you so much for being on camera. Again, as I always say, I think it provides a really rich context for which we can talk to you and actually see faces. So I really appreciate it. And for those of you who are a little shy this morning, we again invite you guys just to get on camera. It just really helps for us here in the studio to reach out to the audience. So my name is Jeannie Dalen. As you guys know, I'm a clinical psychologist and assistant research professor in the Department of Peds, and I'm your moderator. Just a couple of housekeeping announcements. As Kevin mentioned, we are beginning our case consultation forum starting next week, and I appreciate those who have reached out. We have a few who have switched over to next week's date. So starting next week, I believe we have 4 on the book. So if there is anyone else out there who would like to switch, go ahead and get it done next week. We still have a spot open, so reach out to me and let me know. And those who have sent their case consultations, those will be going out for review over the next week, so our expert providers can have some time to look over, and I think it's going to be a really nice, rich conversation and a lot of good advice. To also know that it's not just about our expert forums, but the expertise that you guys bring as well. And so it'll be great to hear any feedback or ideas or thoughts that our audience has as well. We do look like we have a message, Kevin, that Jackie from After Our Peds is having technical difficulties. Okay, so Jackie, it looks like your IT guy is working on it, and Kevin can work on it from our end as well. So hopefully we'll get you up and running. All right, so let's go around the room. We have a packed audience for this morning's Envision studio. So let's go ahead and go around the room.
Andrea Anderson, QA specialist at Envision.
I'm David Fitzgerald. I'm a pediatric resident at UNM.
Kirsten Bennett, pediatric dietitian at Envision.
I'm Allison Venegas. I'm a fourth year medical student at UNM.
Adrienne McConnell, quality improvement specialist at Envision.
Elena Scherer, senior statistician at Envision.
Hi, I'm Jane Beckley.
And I'm Kenna Sheik. I'm a pediatric resident.
Wonderful. Well, for today's presentation, we have the wonderful Jane Beckley here to present for us. Jane is a nurse practitioner and was a formal faculty member in pediatric nephrology, though she's currently retired. But as Kirsten said, we're getting her back on board, and you can't quite always leave pediatrics once you begin. So Jane is going to be presenting this morning, as you guys can see, on the obese adolescent and evaluating comorbid conditions in primary care, which I think is a great topic. So Jane, you have the floor.
Thank you. And I'd like to thank the Envision team for allowing me and inviting me to participate in this whole series of adolescent health presentations. So the topic I was asked to speak about a bit today is evaluating adolescents with obesity for comorbid conditions, and doing that in the primary care setting. A little too fast. Objectives are two. The first is to identify potential comorbid conditions that are associated with obesity. And the second is to discuss the workup of selected comorbid conditions in focusing on a primary care practice. And the ones that I'll really look at mostly are lipid abnormalities, blood pressure, glucose abnormalities, and a bit about PCOS, and a little bit, but not very much, about making reference to non-alcoholic fatty liver disease. So in starting, I wanted to bring up a few questions for consideration, sort of to frame the discussion. The literature that I looked at in going over this question really emphasized how much of the responsibility for evaluating youth with obesity falls to the primary care provider. Evaluating it, identifying comorbidities, and then managing those. And thinking back to the first presentation of this series, I remember Dr. McGrath making a point of how many issues are involved in an adolescent well exam. And so one of the questions I thought of was, do you wonder how to add yet another assessment to the usual 20 to 30 minute well visit for a teen patient? In your practice, do you need to consider the cost in time or dollars for your patient and their family of any workup that you would order? And have you ever observed differences in the workup ordered by other clinicians and wondered, what is indicated? I know for me, that's something I sometimes wondered when I look at what another clinician did was, should I have been doing this? And if I did, and I have an abnormal value, what do I do with it? So just some basic definitions. Obesity and overweight. I'm sure this is familiar to everyone. Overweight means a body mass index between the 85th and 94th percentile for age and gender. Obesity, a BMI at or above the 95th percentile for age and gender. The prevalence of obesity is generally been considered to be increasing. According to Klisch, and this is from Up to Date, 34.5% of adolescents in the US are overweight or obese. 20.6%, or about 1 in 5, are obese. And the prevalence is increased among Native American, Black, and Hispanic youth. Estrada gives a different number, but still impressive. 12.5 million US children are obese, and many of these have one or more obesity-related comorbidities. So obviously the numbers mean that it's quite significant, but in addition to that, it's pretty well documented that if obesity persists into adulthood and weight does tend to track into adulthood, there's an increased risk of diabetes, hypertension, dyslipidemia, and carotid artery atherosclerosis. Klisch also goes on to mention that there are some studies that suggest that if an obese adolescent can achieve a healthy weight in adulthood, his or her risk of these conditions decreases to be the same as an adult of a healthy weight. So there's something to be gained in terms of decreasing risk as well. The most often cited comorbid conditions, first is elevated blood pressure. And there are a number of different estimates of how prevalent this is. What I cited here is from Estrada, whose work was done with the Children's Hospital Association expert work group on obesity. And this is pretty consistent with what you see in other resources that suggest that youth with obesity have about 4 times the risk of healthy weight obese of having hypertension. I have seen higher numbers, up to 30% of obese youth will have elevated blood pressure. Everyone, though, notes in their statistics that, like weight, blood pressure tracks into adulthood. And that was a point made as well by Dr. Wong in his presentation on hypertension at the recent Wilder conference. Dyslipidemia is the next prominent comorbid condition. The lipid abnormality considered the most significant in terms of predicting increased cardiovascular risk is an elevated LDL. But the one that's seen perhaps more often is what's called combined dyslipidemia, and that is an elevated triglycerides and a low HDL. And that pretty much coincides with my experience working in pediatric nephrology, that the majority of the youth that we saw with elevated blood pressure also had elevated triglycerides and a low HDL. Fatty liver disease is another comorbid condition. It is largely considered silent, rarely presents with symptoms or obvious evidence of external abnormality. Also from the Wilder lecture series, Dr. Aldo Maspons, who's a pediatric GI from El Paso, former UNM, pediatric resident, cited a figure of 6 million youth with fatty liver disease. Additionally, there's an increased incidence of prediabetes and diabetes. Numbers for prediabetes vary, according to Klisch, from 7 to 25% of youth with obesity, but 4% of obese adolescents will have type 2 diabetes, undiagnosed or silent type 2 diabetes. Polycystic ovary syndrome affects about 5 to 10% of women of childbearing age and is associated with obesity as well as insulin resistance. Obstructive sleep apnea. Klisch notes a small study, only 64 subjects, but of those, 8% had moderate to severe obstructive sleep apnea. And finally, psychosocial problems, increased incidence of depression, anxiety, bias, bullying, and others is kind of a grab bag. But some of the other considerations are some orthopedic conditions like slipped capital femoral epiphysis. You can have bowing of the tibia. And so the evaluation of your patient begins obviously with a history, some potential red flags to consider in an obese youth. One would be a history of recent rapid weight gain. This would be concerning for a potential secondary obesity. Snoring or daytime drowsiness might be considered concerning for obstructive sleep apnea. Irregular menses, hirsutism, and acne, particularly moderate to severe acne, which has not responded to therapy, is more concerning for PCOS. As I said, most children with fatty liver do not have any overt symptoms, but some may have chronic abdominal pain. And they're also at increased risk for cholelithiasis. So considering chronic abdominal pain is important. A family history of early onset cardiovascular disease, high blood pressure, obesity, diabetes, and liver and gallbladder disease. Psychosocial history, including depression or substance use, and in the individual's past medical history, prematurity, and a large or small for gestational age child. The physical exam, this is a just kind of a selective list. There are certainly many other potential abnormalities, but probably most important in many ways in the physical exam is the blood pressure. And in assessing blood pressure, you want to look at a mean of serial blood pressure readings. Stature is important. Obese youth are often taller than their age cohorts and may achieve sexual maturity a little bit earlier. You may very likely see acanthosis nigricans. In the female patient, hirsutism, and by this we mean a pattern of excess hair growth, which is sort of sexual or pubertal in nature, more facial hair or abnormal appearance of pubic hair. Tonsillar hypertrophy, you may see what looks like a large neck circumference. And if your youth is complaining of leg, hip, or knee pain, which might be concerning for slipped capital femoral epiphysis, you want to monitor this. So the next slide here talks about what are some of the baseline studies that are considered indicated in evaluating a youth with obesity for comorbidities. And those that are agreed upon by all of the sources I could find are a fasting lipid profile, fasting glucose, and an AST and ALT. And those are the recommendations of the 2007 American Medical Association Expert Committee. Those are cited again by Estrada. And at the end, I'll talk a little bit about her work because I think it is a really useful resource to have available. Those studies continue to be among those listed as agreed upon and indicated. Now, there are some additional studies that Estrada identifies that are performed pretty frequently in pediatric obesity centers. And with each of these, the asterisks indicate some considerations or cautions. About 80% of obesity centers will measure fasting insulin. And she notes that this is in spite of the fact that it is not actually in any international recommendations. So it's not an agreed upon study that's indicated. An informal survey of most of the people who participated in this study about why they performed a fasting insulin was either that it was part of a research piece that they were doing, or that they used it for counseling. The next study is a TSH with a reflex to a free T4. Again, more than 80% of the specialty pediatric obesity centers perform this test. However, you can have transient elevations of TSH and free T4 that are a consequence of obesity, not a cause of obesity. In a normal height individual, hypothyroidism is an unlikely cause of obesity. Transient elevations will improve with weight loss. And the real recommendation is to check thyroid functions if you have signs and symptoms of hypothyroidism or a strong family history. Hemoglobin A1C was measured by about 75% of pediatric obesity centers. This is somewhat questioned only in that there are no data yet to say that it clearly is indicated or like as it is in adults has been shown to be an adequate study of mean glucose. However, it does have one advantage in that it can be done non-fasting. And so if you're if you want to do a workup of a youth and you don't think that returning for fasting studies is going to be an option, one option is to do a hemoglobin A1C, and instead of fasting lipids, do a total cholesterol and an HDL. And there are parameters to using that data. And finally, a screening vitamin D. This was performed by about 56% of specialty centers. And here the question seems to be more, do you check when the data or the literature indicates that about 50% of obese youth are deficient, or do you simply go ahead and supplement them? So here are some reference ranges for normal values. Lipids, normal is an HDL of less than 110. If you are doing non-fasting, your reference range for non-HDL is less than 120 milligrams per deciliter. The HDL should be greater than 45 milligrams per deciliter, and triglycerides less than 90. Fasting glucose should be less than 100 milligrams per deciliter. A hemoglobin A1C should be less than 5.7%. Reference ranges for ALT are somewhat variable. In general, there's pretty consistent agreement that standard laboratory reference ranges, which may be what is reported on your result, are considered too high for youth. The most conservative is less than 25 milligrams per deciliter in males and less than 22 in females. Estrada's protocol for monitoring and following an elevated ALT is to follow those with an ALT but greater than 40. So normal or the acceptable reference range would be less than 40. And all agree that the child should be referred or worked up for an ALT which is greater than 2 times the upper limit of normal. If you obtain an insulin, there are a number of different ways to sort of evaluate the significance of that. This is the one I find the easiest to use, and that is a fasting glucose insulin ratio, and that should be greater than 7. To the extent that it's below 7, you're thought to have evidence of insulin resistance. And the blood pressure should be less than the 90th percentile for age, height, and gender, and also less than 120 over 80. So in adolescents, a blood pressure greater 120 over 80 or greater is considered pre-hypertension, even if it's technically below the 90th percentile. Some abnormal findings with respect to dyslipidemia. It is considered a critical value that requires prompt referral for an LDL of 250 milligrams per deciliter or higher, or triglycerides of 500 milligrams per deciliter or higher. Most youth with obesity who do have an LDL elevation are not going to have that high of an elevation. It rarely exceeds 160 milligrams per deciliter, and more often it's probably going to be in the range of 130 to 189. Thompson, who is citing the National Heart, Lung, and Blood Institute here, recommends a referral to a lipid specialist for LDLs of 190 milligrams per deciliter or greater. That's to consider the indication for statin therapy. And in that mid-range, assessment of risk depends on both the number as well as the number of risk factors that an individual youth has. High risk factors would be a family history of early cardiac disease, diabetes, kidney disease, body mass index greater than the 97th percentile. Moderate risk factors would be things like a low HDL and hypertension not requiring therapy, whereas it's high risk if you have hypertension that does require therapy. Intermediate triglyceride levels are between 130 to 500 milligrams per deciliter. That's a pretty big range. In most cases, the recommendation is to consider either a referral to a lipid specialist or omega-3 fish oil therapy for triglycerides between 200 milligrams per deciliter and 499. Further evaluation of an elevated blood pressure. Initially, it's important to assure that you have done everything to obtain the most accurate data possible. Assure a correct cuff size. To quote Dr. Wong in his presentation from the Wilder lecture series, undercuffing is a problem. So it is really important to have an adequate size cuff. Correct technique, making sure the arm is supported, the youth is sitting correctly. The recommendation is to obtain serial readings, allowing at least several, if not as much as 5 minutes in between readings. If you have an elevated oscillometric reading, it should be repeated with an auscultated reading if at all possible. And you make your decision on the basis of the mean of blood pressure readings. Now, if you continue to have pretty clear indications of elevated blood pressure, before making a diagnosis of hypertension, you need to repeat those elevated readings on a series of 2 future visits, at least 1 to 2 week intervals. Sometimes it may be a little bit longer if it's a mild elevation, but the main point is you need elevated readings on 3 separate occasions over a period of time to diagnose a youth with hypertension. Once you've done that, what do you want to look for? Considerations of possible secondary hypertension. Is there a past history of urinary tract infections such that you might be concerned about potential renal scarring? Was there a history of prematurity? Family medical history is important, especially if family members with hypertension were also diagnosed as adolescents or very young adults. This would at least raise the question of whether there's a possibility of a monogenic form of high blood pressure. Even though a youth is obese, which is an obvious risk factor for hypertension, we would not say without looking or considering that this is essential hypertension. Substance use is important to assess. Tobacco, alcohol, street drugs, but also supplements, caffeine intake, and the use of non-steroidal anti-inflammatory drugs. You want to consider sleep history. Again, obstructive sleep apnea is a risk factor for hypertension. Imaging, a renal ultrasound to look at renal sizes, and renal echogenicity. Increased echogenicity may be concerning for some underlying renal disease. Laboratory tests include a BMP, CBC, UA, and quantified urine protein creatinine, and a urine microalbumin. And these were taken not just from the Strata, but again from Dr. Wong's presentation at the Wilder conference. And these recommendations are part of a protocol that pediatric nephrology has developed in working with primary pediatrics at UNM to sort of make it workable in the primary care setting to evaluate and treat youth for hypertension.
So no renin level?
Pardon?
No renin level?
No.
Okay.
Now, that's a good question, though, because you do certainly see that. But
It's in the fourth report. I don't know if that's current anymore.
Well, actually, I think the fourth report is current. I think
Okay.
it's the most, still, in everything I read, it is still the cited reference for evaluating and managing hypertension. I haven't seen anything. The Europeans have a little bit more recent one, but it doesn't, I don't think it differs in that respect. I'm going to tell you why I think they did not include renin. It's a little bit harder to interpret. And sometimes, certainly in pediatric nephrology, we would do a renin and aldosterone, which might be more indicated if you think you have a family history of maybe a monogenic form of hypertension, because those usually mean you have some abnormality in renal handling, tubular renal handling of sodium and potassium. But I think this is written for a primary care setting, and I think that's why it's just the basics. An echocardiogram is indicated to look for left ventricular hypertrophy. In the fourth report, as well as the literature, presence of LVH is an indication to either start antihypertensive medication or increase it if it uses on it. And considerations for referral or consultation would be a normal BMI, which is not the group of people we're talking about here, but adolescent hypertension is more concerning for a secondary hypertension. Other risk factors for secondary hypertension: proteinuria, abnormal renal function, and persistent blood pressures in a stage 2 hypertension range. And that would be greater than the 99th percentile plus 5. Evaluating glucose abnormalities, 40% of children diagnosed with type 2 diabetes are asymptomatic at the time of diagnosis. So screening for glucose abnormalities is important. A diagnosis of diabetes requires that there be abnormalities in one of these documented on 2 separate occasions: random glucose greater than 200 with symptoms, a fasting glucose of 126 or higher, a 2-hour postprandial glucose of 200 milligrams per deciliter after a 75-gram glucose load, and a hemoglobin A1C of 6.5% or greater.
So Jane, you said you just need one of them? Just one of those values?
Well, you need one abnormality on 2 separate occasions. So you could do a fasting glucose twice. You could do a hemoglobin A1C, and then something else. I don't know that people usually just repeat a hemoglobin A1C. I think if you had a hemoglobin A1C of 6.5 or greater, you would probably go to
You'd work up the other.
yeah, probably I would even go to an oral glucose tolerance test. If you have a youth with values in the pre-diabetes range, that's a hemoglobin A1C of 5.7 to 6.4%, or a fasting glucose of 100 to 125 milligrams per deciliter. FLISH recommends obtaining an oral glucose tolerance test. Evaluating for PCOS or hyperandrogenemia, and this is a condition characterized by either anovulation or oligomenorrhea and clinical and laboratory evidence of excess androgens. Estrada recommends beginning a workup if a young woman has irregular menses plus, or even normal menses, plus or minus hirsutism and acne 2 years following menarche. Rosenfeld actually tries to make a point that working up early is important, not necessarily earlier than 2 years post-menarche. Although he does say that you could make a sort of provisional diagnosis if you check a bit earlier in that time. But his point, I think he's trying to drive home, is don't assign irregular menses for too long to a, quote, normal period of variability. In his work, he says that periods which are less than 19 days to longer than 90 days in length are abnormal. And by a year post-menarche, the vast majority of young girls or women will have periods between 21 and 45 days. So he's arguing for don't just write it off. Look, the laboratory workup is a morning sample for 17-hydroxyprogesterone. And many of these studies are intended not so much to diagnose PCOS as to rule out another cause of irregular menses, like non-classic CAH or prolactinoma or other rare but still potential abnormalities. So a morning sample for 17-hydroxyprogesterone, total in pre-testosterone, sex hormone binding globulin, DHEAS, androstenedione, LH, FSH, estradiol, prolactin, free T4, and TSH. The insulin and oral glucose tolerance test I put on there, but that's actually not part of the screening workup. If you have diagnosed a young teen with PCOS, the recommendation is then to do an insulin and oral glucose tolerance test to determine therapy and the need for metformin, the degree of hyperinsulinemia and the need for metformin versus using COCs. It's recommended by both Rosenfeld and Estrada to use a laboratory that will do an ultrasensitive pediatric assay and it provides pediatric references. The usual PCOS picture is going to be a mildly elevated or normal total testosterone, elevated free testosterone, low sex hormone binding globulin, and an elevated DHEA and androstenedione. And then if you see other abnormalities, a markedly elevated 17-hydroxyprogesterone, notably elevated LH, FSH, prolactin, etc., those would be considered a reason for referral to endocrinology. They may, those would be pathognomonic of some other abnormality. Just a little bit about evaluating an elevated transaminase. A true diagnosis of NAFLD and staging of the disease really requires a liver biopsy. It's suggested if you have an elevated ALT if you have an echogenic liver on ultrasound. I think the main take-home point in this is that you want to have a high index of suspicion for NAFLD. Estrada recommends repeating an ALT 1 to 2 times over 6 months if it's in the range of 40 to 60 units per liter. Doing a laboratory workup if it is between 60 and 100 units per liter, and referring if it's greater than 100. Dr. Maspones had a little bit different approach, but again, initially monitoring. He would obtain a full hepatic function panel, GGT, an INR, and CBC, and repeat that again after another 2 to 3 months. If no improvement at that point, he would refer to or consult pediatric GI. And the list of studies recommended for a laboratory workup of elevated transaminases is really extensive. It is aimed or intended to identify potential viral, immune-mediated, or congenital problems. So I didn't really try to put it on here. In summary, you want to assess overweight or obese youth with labs, blood pressure, assessment of sleep, and depression screen. There is an option for non-fasting testing. If the youth has hypertension, you want to add a CBC, a BMP, urine studies, a renal ultrasound, and echocardiogram. If you diagnose diabetes, you would refer. Prediabetes, and consider at least an oral glucose tolerance test. PCOS, confirm with a laboratory workup, and an elevated, or refer, an elevated ALT you want to monitor. Okay. This really talks about ongoing management. First line intervention is healthy lifestyle, and this is the follow-up if you have normal findings. If you have abnormal findings, it depends on what they are and the degree of abnormality and what interventions you're using. Elevated blood pressure, you'll check in 6 months for prehypertensive blood pressures, 3 to 6 months. I would err on the side of 3 for stage 1 hypertension. If LDLs are less than 130 in 12 months, in 3 to 6 months if they're between 130 and 189. Elevated triglycerides, check in 12 months if they're less than 130, and 6 months. And prediabetes.
Sorry, 1 second. Here. My apologies, we had a screen share issue. I think we're back in shape now. Yeah, mic is working.
Okay. And then, let's see. This didn't advance. Actually, this is some discussion questions, but I did want to just quickly go first to this. On the 2 references that I have an asterisk here, Estrada and Thompson, I would recommend for anyone who would like to read further about this, or who wants a sort of real, both of these have excellent algorithms for not just evaluating, but also managing all these things. So if you are, if you're looking for something more to look at, I recommend both of those. They're based on very good data and well worth having on hand. And then these are the other, these are the other references. And this was just a sort of general discussion for me. And I think there was a question too. So yeah, actually the recommendations are to follow an elevated ALT. That is the abnormality which is more specifically linked to non-alcoholic fatty liver disease. I think I would still probably recheck an AST, but I don't think that it is the key issue.
Okay. For those of you who, I'm sure all of you can see the question, but just in case, the question that came up is the recommendation only to follow elevated ALT and not elevated AST? So thanks for that answer as well. Okay, discussion.
So this for I guess kind of, discussion or questions. This is basically a 15-year-old new to your practice. It's an adolescent well visit. He has no issues. Pretty much a negative history. Family history is positive for obesity and type 2 diabetes. No tobacco, drug, or alcohol use. No complaints. He has an elevated BMI at the 95th percentile. Height is at the 95th percentile. Blood pressure's systolic is a little bit above the 95th percentile, and otherwise his physical exam is pretty normal. So what would you want to include in your plan? What constraints or obstacles do you think in your practice or in your experience would you need to consider? And any other comments or questions? Okay.
Thoughts for those out there or in here, actually, in our audience?
So you'd want to make sure that he's resting for at least 5 minutes before you retake his blood pressure. You want to check the cuff size and probably take it 3 times that day. I also ask, have you had an energy drink right before you came in? Obviously, he's not on medications like ADHD meds, but I've read that energy drinks can raise your values 5 points, and you just never know with an adolescent male. And then have them come back. Have him come back or if you're in a primary care practice, call the school nurse and ask them to do blood pressure serially on this kid. That's what I would do.
Yeah, good. And would you go ahead and recommend labs?
Not yet, no. Because and there's a code you can use. It's elevated blood pressure because this kid doesn't have hypertension. He has a one-time elevated blood pressure. So.
Yeah.
We did have a comment come in just to me privately. So we see this all the time, especially with sports PE. And many of those patients are not our patients, but just here for sports PE.
I'm sorry, we see this all the time?
We see this all the time, especially with sports PE. And many of those patients are not our patients, but just here for a sports PE.
Yeah, so in that case, you may not have any option, or you may not think you have an option for ongoing management in your practice. So I think I would at least want to do some education around the potential issues. And in addition to blood pressure, certainly a metabolic workup would be reasonable for someone to do if it hasn't been done. And we don't know where that stands because he does have an elevated BMI that is above the point where a basic metabolic workup would be recommended. Now so I think if you don't know that you're going to have a chance for follow-up yourself, then education and potentially enlisting, if it's a sports PE, he probably is in school, probably is playing for someone's team, asking the school nurse if she can continue your monitoring.
And he needs fasting labs, right?
Well, fasting, or if you don't think you're going to get him back, then you could do a random A1C, total cholesterol, HDL, and the liver function tests. Those can be done non-fasting. And all of the literature will give you parameters for evaluating a non-HDL cholesterol.
So we have a couple comments and questions. From Gustavo, he said that I agree with the energy drink. I had a student come in after a night shift from work with elevated blood pressure, but at 2-week recheck was normal after advising patient not to use energy drinks. So it sounds like that's a common issue with the energy drinks or the caffeine intake for some of you. Sandra mentions, I was screened for diabetes and check lipids and AST, ALT.
That would be indicated by his elevated BMI, yes.
And Betsy says, you know, I believe, Betsy, this has to do with the blood pressure, or any anxiety issues can affect the blood pressure readings as well.
Yeah, I mean, anxiety certainly does. And probably in the setting of a well child check, there might be some anxiety. What are you going to ask? You know, what are you going to ask while my mother's here? Those kinds of issues. As well as I mean, it's pretty well documented in the literature that white coat hypertension is not a rare phenomenon. It's also not something to be entirely dismissed, because like prehypertension, there's some thought that white coat hypertension kids are at risk of ultimately having higher blood pressures. But yes, anxiety for whatever reason, caffeine intake, whether it's an energy drink or, you know, a big something from Starbucks on the way in.
Do you guys coffee? Okay, Sandra also says, I think trying to get the most accurate school blood pressures is pretty key too. So connecting with the nurse, the cuff size, to make sure that the protocol being used is correct.
Yeah, I think that is important, because it is important to know if the school has available a range of cuff sizes. You know, I mean, some of these kids, the truly extremely obese kids, we've actually used a thigh cuff. And it is, you know, it is at least important to have an extra long, large adult cuff if you have a large arm circumference.
Jennifer comments, this is not particularly relevant to this topic, but I would check blood pressure in both arms.
Actually, it is very relevant. And it actually reminds me of something I was going to say and forgot. And, you know, one thing that's worth doing in your assessment of blood pressure is at least one time doing either 4 extremity blood pressures or both arms and one leg. And when you do that, you have to have the individual lying down. You can't do a lower extremity blood pressure on someone who's sitting up. But what it is, it's a very rough but still potential screen for a cohort. So if you have upper extremity and at least 1 or 2 lower extremity blood pressures that are relatively similar, you probably don't have an underlying cohort. But it's still, it's not hard to do. It's not a little bit time consuming. But if you can do that, that is worth doing.
Great. So I think you gave also, Jane, some interesting questions for people to consider at the beginning of the presentation. And so just as a reminder, it was more around, you know, this idea of when you only have a 20 or 30-minute well visit, the idea of actually doing one more assessment or one more workup. And I'm just curious if anybody has any comments or what your experience has been in your clinic as we add different type of tests and different type of workups, and the ability to do that in the clinic. And if cost does become an issue, cost and time for what you can actually do in your clinic. it appears maybe that everyone, this is something that, I think with obesity being so predominant, unfortunately now, I think it just becomes, something that it gets included much more often now than it did before. Jennifer did say, for my school-based health clinic population, cost of the lab workup or ability to afford specialist care is a challenge. I can imagine. Betsy, I think you had mentioned, I think it also depends on the time of the client. Can you tell us a little bit more about what you mean by that? Perhaps it's, so sometimes they don't have enough time, right, to actually even do it themselves. I agree. Yeah, it can be constraints on both sides. Absolutely.
And I have one more comment from Jackie. Sorry, just scrolled up. We send out for all labs except HGB and lead, so patient compliance is more of an issue with sending them.
Sending them to the workups. Yeah, it sounds like a lot of this is coming up, like transportation issues, at school-based health centers being able to obtain follow-up appointments and studies from labs. Yes, absolutely.
I'm curious if anyone out there is using finger stick glucose or what you think of that. We're not, but I often wish I had it because I can even do a 2-hour glucose tolerance test at school with a finger stick, if very easily with just food, and it's not expensive. Mm-hmm. But we don't have a glucometer to use. So.
Yeah. I don't know of any studies that actually use that, but it's a good point. Is could you at least screen for a fasting and a 2-hour postprandial after a normal meal, and at least have some idea of whether you have truly reassuring values or something that would be your reason to pursue it.
I think there's a couple good comments coming in as well about parent buy-in, that sometimes not even just the time, but actually getting the parents to buy in and make the time to take kids to appointments and to actually get them to become serious about, behavior change practices and labs. And I actually think that's a common issue or challenge across the board for many of the other sites across the U.S. that I work with. And so just to let you guys know, parent buy-in is something that I believe, as we start getting more to the behavioral health side of things in the spring, we will be talking more about that, about best practices to work with parents when a lot of these behavioral health issues, and now I'm hearing not even just that, but even just getting people to go to get labs can be quite an issue. So I agree with that. Sandra, just a couple more comments. I know we're at the end of the hour, but these are some great comments coming in. Sandra, I have a glucometer, but I usually just go straight to HbA1c and draw at school and transport back to Shiprock Lab. And then Jackie, for the school-based health centers, where is the child's medical home? Who becomes responsible for all the follow-up? I think that's a great question.
Really good question.
Yeah. Any thoughts on that one from those who worked in school-based health centers?
I mean, if they have a primary care provider, we try to get them back with their primary care provider and hook them up there and supplement that if requested by the PCP and the family. But often we're the only source of care, and that gets really tricky. Yeah. I'm not dealing with diabetes much, but for anything.
Absolutely. Well, I appreciate all of the questions and comments that came in. I think this was a great discussion at the end, and it shows that these challenges are not easy. Knowing the protocol, knowing what we should do is one thing, and then actually implementing it and taking care of the patient and getting the patient to have their side of the responsibility is something that we all have a challenge with. And as I mentioned, hopefully with that, we'll be working on some of those issues in our behavioral health section next spring as well. So appreciate it, you guys. I know we're at the end of the hour and everyone has a busy day and meeting. So this is great. Thanks for the turnout, and thank you, Jane, for presenting on a great topic with some great information and references. And Kevin sent out the link to the post-session survey, so just take a couple seconds to fill that out, you guys. And we'll see you next week for our first case consultation forum. Thanks so much, everyone. Have a great week.